Happy New Year, happy Monday. Welcome to this first episode of the Compliance Guy. I am so excited to welcome back my very good friends, Christine, Stephanie, Terry, Scott, and Paul, in no particular order. But everybody is back, and we have a great show in store for you. If you are watching us on YouTube, LinkedIn, Facebook, X, or on our own studio here at Riverside. So, we have a great program for you today. I'm really looking forward to having these conversations on what can only be described as nightmares for some of y'all that are dealing with telehealth services, dealing with the use of non-physician practitioners, or other ancillary support members of your organization under the Incident to billing provisions. We're going to save that conversation for last, but we're going to jump in because I think the biggest issue out of the gate really is surrounding all of the stuff that's going on with telehealth services, the variations between the codes, the coding guidance with what's put out there by the American Medical Association versus what the Centers for Medicare and Medicaid services are accepting. There's also variances going on with the commercial insurance companies, and they're restricting the use of telehealth services in certain ways. And I'm going to let our esteemed panel of experts talk about this. Since Terry has been my Yoda on these services throughout the public health emergency, really, I'm going to let Terry kind of kick us off and get us rolling down the road. And then we'll open it up to Christine, Stephanie, Scott, Paul, and let's just kind of get after it.
Okay, Happy New Year, everyone, and we're all happy to be here. We're going to try to put a positive spin on this when there really isn't some for some of you. So we're going to do our best. Kind of look at this as we're giving you the rules, how you choose to use them. I feel like this is a Mission Impossible intro. How you choose to use them is entirely up to you, but just know we're trying to make sure that you're compliant in the new year, that you're not trying to get around anything. I can't tell you how many times our whole panel here of Hollywood Squares, where we're all hearing that a lot of times, where, how do I get around that? Well, this is what I heard from this source that said I can do this. And we're here to tell you this is what the published guidance is telling us. And, as participants on the compliance guy, we're all about compliance. So here we go. So the first thing that we found out, and obviously we started or ended the 2024 year with letting you know that Congress did pass a 90-day reprieve on telehealth. But what that means is that for the current state of our office and other outpatient services and some of our hospital services, audio and video are still allowed for 90 days. That's through March 31st, 2025. What the rules you've been using, the place of service would be 10 if the patient's at their home. If they're not in their home, it's 02. And then private payers are doing whatever they want to do. You have to really look at their guidance. Some are following Medicare, some are following their own, and I'm finding a lot of them are just doing what they want to do specifically. Now I'm going to fast forward to and that doesn't have any kind of diagnosis controls. Audio and video, it's just what we've been doing. Now audio only, this is where we get into a lot of, I know, heated discussions, a lot of discrepancy, a lot of people saying, yeah, but. Okay, so first of all, we know that AMA, CPT, put out some new codes for office visits and for audio only, and they are specific to telehealth. Medicare has put them in an I status, saying that they are invalid because they say there's already codes you can use. Well, as we know, the audio only phone call codes were deleted, so technically that's not true. There are 17 new codes. Medicare is only recognizing one, which is the 98016, which is for a virtual check-in. But remember, that's not on the telehealth side. What that is that's been around since the G2012. That's considered the communication technology service, that if a patient might need to come in, then you may get $10 just to tell them over the phone. You don't need to. We'll call in a prescription. You haven't been here in at least a week, and you're an established patient, and it's somebody who can also bill directly to a payer E&M services. So This is not a medical assistant charge. This is a nurse practitioner, PA, or physician. And
again,
it's,
Terry,
again,
it's
$10.
not to call and give the results
No.
back to the patient that was previous in the office, or to call the patient and say, hey, I refilled your meds. This is for a real problem that's being discussed for that brief virtual check-in.
Now, what this is a patient who, let's say, had urinary tract infections, and they came in for an in-person visit, let's say a month ago. You gave them Augmentin or you gave them some kind of antibiotic. It worked. They went away and said, I don't need to be seen for 3 months. Well, that patient felt one coming back on, and they called the office, spoke to a nurse practitioner. 5 to 10 minutes of medical discussion was documented with that nurse practitioner. And they said, we'll go ahead and call it back in. Let us know if you have a problem. They didn't say, we'd like to see you for the first available appointment. If they do, you have to add that time or that visit to that appointment. But they just said, we'll see you in your 3-month appointment, and sent them on their way. You get $10 for that, 98016. But again, initiated by the patient, exactly what Christine said. It's not to give test results. It's not what everyone's been doing for the kind of the abuse of the audio only. So we don't have an audio only option right now, unless, and then I'm going to switch it over to Christine or Stephanie, unless it's for specific diagnoses. And those diagnoses are end-stage renal disease clinical assessments, or they're for behavioral health diagnoses, or they're for substance abuse related disorders. And please do not make up diagnoses. And only if the patient says that I cannot or refuse to do audio and video, and the provider still has an opportunity to connect them, but for some reason the patient can't. That's the only exception to that rule. Regardless of what you're hearing out there, you're going to be going down a path that's not good to do that. Also, that we're talking Medicare. And before I send over to Christine, real quick, one of the things that you also need to look at, and I sent it out to the panel over the weekend, Aetna, Blue Cross Blue Shield North Dakota, Blue Shield, Blanket, and have the same rule. They're not recognizing the new codes either. And also remember that a lot of the private payers like United Healthcare and Cigna on audio only got away with that a couple of years ago. So they're not going to keep reiterating a policy that they already have in effect. All right, Christine, go.
So sorry. So no, but I was going to interject there. You said something so powerful, Terry, that I think everybody needs to stop for 1 second and realize. Terry just said your urologist cannot use a primary diagnosis of depression in order to use the audio only. I don't want to say loophole, because it's not a loophole. It really is meant and designated for mental health and substance abuse. We have a huge shortage in the United States. But remember, your taxonomy is associated with your NPI number. So you're not going to get away with your urologist, again, using depression to cover an audio only visit. And again, the reason that this is my personal opinion, and many of you might feel the same way on the panel, it's because audio only was abused. It was abused for calling in test results that are part of the E&M that you were paid for. If you acquired the sample and you ordered the test, you were to use that for diagnosis and treatment of that E&M service. It's not for just calling in and refilling meds. That doesn't even require a visit unless there's a change or an analysis that's part of a plan of care, guys. Like, we need to be really careful. And then the last thing before I punt again is, remember that we're talking about CMS guidance. And like Terry said, a lot of the commercial insurances are following suit. You do have to do your due diligence. All the providers, all the payers that you're participating with today, go and look at their policies. See what you can and cannot do today.
Right. Well, I want to say one more thing before Stephanie takes over here. Remember, audio only was only released and they opened it up actually April of 2020 at the height of the pandemic, because we had a lot of patients, still do, but we had a lot of patients that didn't know how to work their phone as far as audio and video. It was a way to connect with patients because they were told to stay home if they were high risk and not go visit their doctor. The pandemic ended 2 years ago. So we have to be careful about abusing or trying to get around a system that was put in for a particular purpose because we had the convenience or the free-for-all. for this length of time. And there's a reason why Medicare isn't recognizing those codes, a reason they put in the final rule, page 140 and 141, thank you, Christine, of where you find those diagnoses. And I mean, we have the paperwork. This is the published guidance we're giving you, not our interpretation. Okay, Stephanie.
Yeah, so one thing I want to highlight is the behavioral health side of things, because I actually have a large client that I was researching as much as I could. One other thing to remember is that if you're working with a consultant or somebody outside, we don't have access directly into provider portals. So there may be times that we need to come back and partner with you to get access to those policies. But one thing I did find is, just like Terry and Christine are saying, there are exceptions on the behavioral health side. So if you have a practice that does both types of services, or your large multi-specialty hospital group, whatever it is, you have to research your behavioral health completely separate from the regular policies you're looking at for everybody else. Across the board, there is exceptions for audio only with all of the policies I was able to follow, but again, specific to behavioral health. One other thing with that too, when we think about it, a lot of times people tend to think more of psychotherapy and not recognize the side specific to medication management, things like that. So we want to be careful not just defaulting a code to get paid, like Christine said, but it is the full scope of those particular services with behavioral health and substance use. Now, one other thing I just want to point out that I've gotten asked as we were preparing for this year and looking at all of the changes, sometimes people will say, well, how does this national company get to do what they're doing? Or, it's really happening more on a larger level with the national groups. My answer to that is, if you look into the structure of their organization, they don't always accept insurance. So when they're cash pay, they're going to have to go in and look at the state requirements, but they're not going to have to follow everything that these payers are saying they will reimburse. So there's a lot of things out there, and really, from my perspective, the only way I've been able to tackle this when clients have asked me to is to sit and go payer by payer, state by state, and look to see what everybody's saying individually.
Well, one of the things, one thing, Terry, and I'll throw this back to you because I think this may be where you're going to head here, or at least set you up to head that direction. I think it's critical that you make a resolution for yourself this year, that you're very careful with whom you're listening to and what information you are taking as gospel. I know sometimes we look at certain sources and we think, well, it's coming from this type of an organization, so it must be accurate. And for whatever reason, it winds up biting you in the backside. Be very careful about where you're getting your information from who you're accepting guidance as the ultimate, this is how it is. I will tell you, I scour the interwebs all the time. I spend a lot of time on different sites, the different groups that I'm a member of. And I will tell you, I'm always skeptical when I see somebody say, this is 100% the way that you got to do it. This is definitively the way. And there's no citations to anything. Be cognizant of where this information is coming from, because again, there is no payment for audio only services. So be cognizant of that. Be careful with that. Terry, go ahead. I didn't mean to step on what you were getting ready to say.
Stephanie said something I just wanted to clarify as well. And this is something I ran into with a payer and a client, that they got in trouble doing something like this, because I'm sure the totally separate septic concierge medicine comes into play sometimes with practices. I have a provider say, so since Medicare is not going to cover audio only except for behavioral health and end-stage renal disease, does that mean that we can go ahead and charge cash for these? I'm like, no, because that you're not understanding the rules. Medicare does cover it, but they cover it on a limited basis. They're not covering it for those diagnoses. cash pay for Medicare, Medicaid is another story, but Medicare and government payers, and then also commercial plans, make sure you know what their rules are, means that it is a non-covered service blanket. And then you can have them understand kind of financial policy waiver, whatever. But if there is coverage, whether it be a frequency guideline or a limitation such as the diagnosis situation we're dealing with as far as audio only, you can't go back and tell the patient, well, we will do it, but you have to pay for it. That oh my gosh, Medicare will have a nightmare with that.
So that raises a really good point, because you're talking about limited services, right, for Medicare. Well, we know that with Medicare, the rule for the use of an ABN, and I want your thoughts on this, okay? I'm going to give you my perspective. Because if you look at the structure of the R131 form and you actually read the guidelines, it says an ABN is to be used in situations where services are covered under certain requirements, but there are limitations to the extent for which services would be covered. So again, an ABN is not to be used for excluded or what's the other word that I'm looking for?
Never covered.
Yeah, non-covered or excluded services. Thank you, Scott. That was a tough word for me today.
Statutorily excluded.
Statutorily excluded. Thank you. So as you can tell, it's my first day back to work, and I'm just getting my. This is what happens when you begin sharing a brain with 5 other people. I feel like that's happened here. We're able to finish each other's sentences. But where I was going with this is, in a situation where we have a Medicare beneficiary wanting to utilize an audio-only service, but we know the limitation of these is for behavioral health services, for these specific codes, these specific diagnoses. Question to the panel. If a provider were to get an advanced beneficiary notification signed prior to rendering the services and use the GA modifier, would that allow them then to use the audio only services? I'm just asking. I'm not saying I know the right or wrong answer at this point. So I'm going to throw this to you all.
Personally, I'd love to see the moving parts of this when you're dealing audio only and the patient is in their home.
Well, you send them an email with the attachment. They sign it. They send it back. I'm just, listen, you got to remember, Terry and I talk about this all the time. I'm always thinking outside the box, right? And, I'm thinking about ambiguous guidelines. I'm thinking about, how does a provider cover their assets, right? Is this a possibility? Now, there's a lot of moving parts. It may be more of a headache than anything. But again, I'm asking. I want to throw this out to Terry and to Stephanie, Christine, Scott.
My problem with it is that the office visits are not on the Appendix T for 93, so you can't use it there. You can't. So I'm looking at it as how can you justify it? It is like you said. It is the office visits are covered, but they're not covered for audio only. And again, because Medicare puts such a specific diagnosis attached to it, I think it's almost like trying to get around it. And I have a problem with it. I just don't see how you can justify it. But I'm good
with that.
But I see your point, Sean, because I know people are going to come to you saying, but this is what the ABN says. That's why I tried to say a financial understanding that this isn't, just isn't something that's covered.
See, this is the confusing part. And Terry, I know that CMS will answer your questions when you get onto these. I
audit for them. So
these quarterly meetings that they have. They won't answer mine, but I know that they've answered yours. Maybe this is a good question to pose to them, which is, look,
Christine, what do you think? I mean, you deal with this too.
So I want to say, you got to remember, last year, AMA put in the CPT book the guidance for telehealth services. They did address that there were certain codes that they felt could be performed audio only. Again, not saying anybody's even going to pay those, but we as the AMA said these things are safe to do audio only. And then this year, in the 25 book, AMA gave us a lot of guidance on when we should and shouldn't be using it. So I think before we even go down the rabbit hole of ABNs, I think we need to really realize, is this visit truly meeting all of the the guidance to even consider an audio only visit? Is this trying to keep the patient out of the hospital today? Trying to take care of an exacerbation today that they absolutely don't have access to audio video? The provider does, and that the outcome of this visit is going to have the benefits that are expected today. Now, again, then I think if we have that demographic of patients and we can prove that that is indeed the case, then we can start talking about ABNs. But really, we're sitting here fighting for a modality that
I don't
may
think
not
it
be
is.
appropriate anymore.
This is
Go,
it's
Scott.
such a tough conversation because I'm in typical Libra fashion. I agree a little bit with everybody. And I think one of the challenges that I have sometimes when we talk about the today stuff, it is such a judgment call in the eye of the circumstance, right? Like if I have a small amount of like cellulitis or something and it seems to be fairly innocuous, but I don't want to get off my butt and go in the office, and I'm willing to consent to this audio only visit and pay for it, but it somehow doesn't seem urgent and then it becomes urgent. Like I kind of struggle with that. Like I compare it to like chronic care management, right? Where chronic care management has all this language about serious chronic conditions, right? Well, what is a serious chronic condition? Is diabetes serious if the patient manages it well and therefore the patient's generally stable, right? So if I go into chronic care management because I say, well, I want to avoid crazy exacerbation, it is a serious condition. And I don't know if that makes sense, but I think in the construct of this, like what gets me about it in some ways is I always feel like when I tell somebody they can't do something, I have to point to the place that says like why or where, right? And to me, I think a lot of this phone stuff, I hate to say it, but it's like the patient's just going to be like, look, if I don't have to turn on a video and I have to get dressed and get out of the house, and I'm willing to pay you $60 or whatever it costs, $90 just so I can get this prescription, which frankly is really the desired endpoint to a lot of this, right? It's like, well, I need a prescription. I can't get it myself. If I call you and I ask for an appointment in the office, you're going to tell me to come in on Wednesday, but I can just jump on the phone and give you money, right? I think that's the disconnect I have in some ways where I understand the compliance aspect from the practice side. That's the part I'm sort of going through in my head.
Well, Scott, I had the same thing. I was talking to Sean about this recently, that erroneously, my doctor's office charged for a shoulder injection that I never got because I couldn't make the appointment. And then I called and questioned it, and they're like, yeah, but you didn't have a copay. I'm like, but I didn't have the injection. They didn't understand why I was mad because I didn't have an out-of-pocket. And I'm like, but you charged my insurance company. I'm like, they're like, yeah, but you don't have an out-of-pocket for that, only if you came in. And I'm like, exactly, I didn't come in. So they're like, no, only if we also build an office visit. I'm just
They
like,
squirted into the air.
I know. And so
But
basically they said I missed it, but I never got the appointment, there. So they basically said, just because we build the insurance company, if you don't have an out-of-pocket, why are you mad? So in what you're saying, a lot of people, and I always laugh when I hear all this, oh, hospitals have to be transparent now. Patients don't care. They're not shopping around for that transparency. They only want to know what their out-of-pocket is, unless they're one of us.
Let me
Right?
say something though. Let me say something real quick, Terry, on that. So insurance fraud isn't just limited to the provider. Okay.
I know, but you get where Scott and I were going with that. It's just, if I could just pay for it, or if I, why am I worried about it?
But no, I'm with you. I'm with you. But think about this, okay? If you as a patient and as a beneficiary of the insurance company know that there is a perpetrated fraud against the plan, and you are complicit and you do nothing, but you had knowledge, you're an accessory potentially to the crime of a fraud committed against the insurance company. They could prosecute you. They could drop you from the insurance. So if you become aware of a situation similar to like Terry happening to you, you should absolutely reach out to your insurance company so that you're not used as the scapegoat where the insurance company says, but wait a minute, Terry Fletcher knew that we billed her insurance. She knew that, blah, 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 blah.
Right.
Be
yeah,
careful.
And I see what you're saying, but the problem is nowadays we have a remote control and a delivery message and a method, and virtual for everything. I mean, there's a remote
Yeah.
control for a remote control for a remote control. You know, so to me, that's what audio only telehealth is. I think I like it for behavioral health. I think that that's a really good change, because I think that, you know, mental health, behavioral health patients, they need to have that kind of outlet. And I'm sad that like what Christine was saying, that the abuses of the audio only, you know, in the past 2 years, 3 years actually, really have hurt patients in rural areas that never got, you know, connected to internet. And so this is gonna hurt them more than anything if they,
Yeah.
you know, initiate a call and need it. But you just can't stop bad actors. You just
Yeah, I mean,
can't.
I don't. I think we've all seen the abuse on it, right? Like, I
Yeah.
would love to. I wish we could have, like, now that the football season's over, I'll use an analogy. I wish we could have like a statistical ranking of like the
We're
percentage
in
of
the
video.
playoffs, but okay, go ahead.
I'm a New England Patriots fan. The season is over.
Yeah, your coach got fired.
As is
Sorry.
your coach. Yeah.
They didn't even let him walk down the hall. They were like, "You don't need to go in there." Anyway, I would love to see a statistical ranking of doctors based on the percentage of audio-only telehealth visits, because you see those statements, right? Like the patient didn't want to get on the phone, or they couldn't get on, or didn't want to get on the video, or they couldn't get on the video, or they whatever with the video. And I know when we had this conversation about, well, the way you do it is you email the person the attachment, and they download the attachment, and they somehow put an e-signature on it and they send it back. Like, that person should be able to get on the video. Like, my dad has like no chance of getting on the video, but he has equally no chance of downloading a PDF, applying any sort of signature to it, electronic or otherwise, scanning it in. Like, it would take him 2 weeks to figure that out. Now, for me, like, what was interesting though, in terms of the audio only, right, is so if I wanted like an MRI, and I'm just one of those people, and I want an MRI and I don't have a diagnosis, and the doctor's trying to talk me out of it, but I'm like, you know what? Like, my ankle's bothering me or my knee's bothering me, and I want an MRI and I'm willing to pay for it. I don't think anybody here would say that that was a problem from like an ABN perspective, right? Like, I have some diagnosis, but it's not a covered diagnosis, but I have decreed as the patient that I want this anyway, and therefore I can have it. And that's the part where I'm wondering about audio only, right? So we have this list of diagnoses, and I'm saying, well, you know what? I don't have one of these diagnoses, but I'm the patient and I want it. And I'm willing to sign for it, and I'm willing to pay for it, you know, whatever the usual charge is. Like, why wouldn't I just be able to get it, right? Like, understanding, you know, obviously, like, I think the patient, you know, patients are, right? Like, if something suddenly costs me like $150, my need for it may decline. So I wouldn't anticipate like some en masse usage of these services that patients are then paying out of pocket for. But hypothetically, that was where I was coming from. Like, why wouldn't I just be able to do it like a lab or like an MRI that, like, I clearly don't have a basis?
In the real world, Scott, that's not what's happening.
No, of
They're
course
they're
not. But I'm
using
just
the
saying,
audio
like,
only inappropriately, and they're gonna. I don't know. I'm
no, I
frustrated by the
agree
whole
with
thing.
you. I think the issue would be like if I, as a person, just said, hey, you know what? I'm sitting here in my boxer shorts. I feel like crap. And I just need to get this medication, and I don't want to put on pants and drive to the office and sit in the lobby. And if that's cost me $150, I'll pay it, because those people exist.
Yeah, but you
Yeah.
got Teledocs, you got MD Live. Not that we're promoting any of those companies, just saying that there are those companies that my kids use it. My kids don't even use their insurance. They just pay the $55 and they get what they need. They swing by the pharmacy. That same scenario. I don't feel like putting pants on. They don't have to.
But,
And
you know,
speaking
part
like
of
that too.
but, you know, when I think about that as a medical office, right? Like, that's
Yeah.
not bad money, right? Like, if I've got
Right.
like a crop of, if I've got three to five patients a day who are willing to pay that money and willing to say, like, what you just bill it out as level 3 or level 4. You don't bill it, right? You code it out to whatever it is, and whatever that charge is, I'll pay it.
Well, the other thing too, I noticed when I sent out the policies to you guys for Aetna, Blue Cross, Blue Shield, whatever, I noticed they had a little blurb in some of their policies and plans that said they have to use panel physicians now for
Yes.
telehealth, which
That's
are
what I
not
was gonna say.
yeah,
Yep.
they're not the patient's doctor. They're actually employed by the insurance company, which that's a whole other problem for me. And so they don't have their history, they don't have any of their background. But of course, it's probably going to be, the cheap help from the payer that saves them money that the patient has to go through. I mean, there's a reason that these plans are not recognizing these codes. This is going to be, and remember, people, this is only for the first 90 days. We're going to find out probably, I would say, mid-March, what the plan is beyond that. With the new administration coming in, we have new guards at the gate, so it's only for 90 days.
All right, so let's take a natural pause here. This segment is brought to you by MD Live. I'm just hoping that we can get a sponsor. Okay. Let's
have one. I actually have one. I can go ahead and do that right now if you want me to.
All right. So look, I think the bottom line comes down to this, right? You've got to understand, and this is where I think the compliance comes into place, right? Because you're going to find some nuances between the different plans, right? Between what Blue Cross Blue Shield says versus what United says versus what Aetna says versus what CMS says. There's going to be some nuanced differences, right? Because I don't know that there's another policy that you all have shared with me that says it is limited to only panel physicians outside of the UHC one. Are you aware of?
Well, Sean,
Go ahead.
So in the research I was doing, one thing you have to be careful about is when you go into the website, there's the patient side of the information, the provider side of the information.
Right.
When you go to the patient side, it will show you all of these services available to you.
Right.
And to Terry's point, some of them specifically said, I'm just going to paraphrase here, but through their platform, and they would introduce what that platform was.
Right.
And that's where their coverage exists.
Yep.
So I've started to see that. I don't even remember who the payer was, but I started to notice that as I was researching in general.
Well, this is one of the reasons why patients have to take accountability for their care. Because, I love when I have somebody from one of the practices where I serve as a compliance officer. They call me and they go, I have a patient who's griping about blah, 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 blah. And they say, could you please give him a call? And I call the patient and I say, hi, this is so-and-so, blah, blah, blah. What's going on? And they say, well, I have Medicare and my insurance pays for everything. Well, first off, Medicare doesn't pay for everything. They have their services that they consider to be covered, and they have others that are non-covered. And we go through this whole thing, and sometimes they understand it, sometimes they don't. It is what it is. But I think what it comes down to, and this is where I was going from a compliance perspective, the best policy that you can put in place with respect to how you build telehealth services to the different payers that you participate with is to have a copy of their medical coverage guideline in your compliance manual, to have the LCD or the NCD from Medicare or your MAC in your compliance manual, and then make certain on a quarterly basis that you're keeping up with this to make certain that if there is a change, that you are supplementing the existing policy with the new policy or with the revised language in that policy. I think it's very important. Again, you saw, I raised a question to the panel, and I am in complete agreement with the panel on the use of an ABN with respect to the audio only services. I think there's a lot of barriers, to Scott's point, regarding his 80-something-year-old father. That joker knows how to play a slot machine, but you ask him to put a signature onto a PDF, and that's just not happening. You ask them to log on to a certain platform. That's not listen, I have an 83-year-old mother who's got, moderate dementia. I told her that she was getting an Instacart order from Publix 6 times between 6:15 and 7:15 p.m. Guess what? She wasn't there 20 minutes after I told her what time her Instacart was arriving. She was at the pool. How she remembered where the pool was, I don't know, but she couldn't remember that Instacart was coming. Anyways, look, I think telehealth services.
We're very sorry that he outed you. Just wanted to be that person, Mrs. Wise.
Listen, if somebody is in the Boca Raton, Florida area and you are a certified home caregiver, give me a shout. I have a lady that is in desperate need of help. Actually, I need the help more than she does. Okay.
Might see if you could swing over to the Gulf side when you're done. Got another live one.
Yeah, we'll cover mileage. All right. So I think where I'm going with this, and panel, I'm going to give you all the last word on this here in just a moment. We'll go around the table. I think people need to be conducting their own internal audits of any telehealth services that you have rendered during 2022, 2023, 2024. Critical, because remember, the look back period for Medicare on these audits is 6 years. I think you cannot ignore your commercial payers. I think during the public health emergency, targets, this was a moving target. I equate telehealth services in the same way that I equate laboratory testing during the public health emergency. And we are getting requests from law firms. I just got another one this morning for a UPIC audit for laboratory testing tied to COVID tests. Folks, this is a significant look back. If you don't have the internal resources, you've got multiple competent people here with Sterling, with Stephanie Allard, with Terry Fletcher, with Doctors Management. You've got competencies and capabilities to help you with this. My point is, don't bury your head in the sand like an ostrich. Don't turn a deaf ear or a blind eye to what's going on, because there's something referred to as a reverse false claim. And that's the last thing that you want to deal with, which is, what was your mindset at the time the services were rendered and billed? That's where the prosecutors get you. Scott, you were going to say something, and then we'll move on to incident 2.
Yeah, so a couple of points I did want to make. First, with regard to the lab point that Sean made, and this seemed to take off during COVID, and for me, it still hasn't fully come back to earth. But this idea that the patient comes in and they don't feel good, and I see this a lot in urgent care, and there's this suite of labs that you order, and it's like the provider wants to look at all the results, look at all the labs when the provider comes face to face with a patient. And I end up in these situations where I have, rapid strep and strep culture, and I'm going in, I'm looking at the note, and the patient's throat is a negative all the way through. And so I do think I did want to make that point about labs, because I still see that even after COVID. And also with regard to telehealth, be mindful of Medicaid. Medicaid has brick and mortar requirements for telehealth. So this idea that, you're going to do it from home routinely and you're not going to have any sort of brick and mortar location. But also, Medicaid is its own animal in terms of coverage, terms, and conditions. And for better or worse, they often reflect, the politics and culture of your state. So, one state may have a much more liberal application of when a patient might be eligible for a certain type of telemedicine or telehealth service than another. And so you do have to have that familiarity as well, because we haven't talked a lot about Medicaid, but I know I work with clients in some states. It's very high Medicaid population. And, I think in some instances, I've seen a heavy movement to audio during the pandemic, because I think their mindset in some ways, or at least some of the mindsets I've seen, is these visits pay so poorly to begin with. Let me just rack them up on the phone. And you may find that that's going to get you in trouble here in 2025 as well.
Well, I wanted to piggyback off of that. So the state of Florida doesn't even allow telephone only. There was a small period of time during the Florida state of emergency where there were some waivers and flexibilities that were put in place for Medicaid. But once the state of emergency was over, we went right back to the policies that are in place. So if you're doing that today, if you're doing telephone today, you're not supposed to get paid from Florida Medicaid. A lot of the Medicaids are like that they just don't take the audio only. We've got to do a better job, people, of making sure that we're billing things appropriately and not falling on, well, I got paid. I hear that way too many times as validation, and then later on, 2, 3, 4 years down the road, we get the call that they're being audited and they're taking back hundreds of thousands, if not millions of dollars from a practice that can't afford to survive. So we have to do a better job.
As far, as far as I just wanted to make a final point about ABNs and audio only visits. People always focus so much on sections G and H of an ABN form that basically says, I want it, I don't want it, here's my signature, here's the date. You have to focus on sections D, E, and F of that form. What the services you're providing, why Medicare may not pay for it, and most importantly, the amount of money you're going to charge for it. So how are you going to justify that from an ABN as a responsible compliance professional? I would tell any practice who was going to think about doing that, do not do that. It's going to look a lot like a blanket ABN situation for a service that doesn't have any payment. And if you're trying to put a CPT code in there, it's not something you can build in Medicare. So section D, E, and F of that ABN form basically invalidate any attempt you could possibly make to get audio only paid by Medicare.
I just want to make a point too, as far as something that Christine said, as far as your state, state versus government versus commercial plan. Also make sure, especially with the brick and mortar and just with everything that's out there, published guidance comes in many different forms. It's not just the CR we had, which is the continuing resolution from the Congress that just got closed out. That was for to stop shutting down the government. And they gave us 2 whole pages, 6 paragraphs on telehealth. That was it. And it was very unclear. They just basically said everything is, we get it till March of 31st of 2025. Scott, I want whoever's in your background, I want whatever he's having in the refrigerator. Anyway, I just thought it was funny. Then just make sure that you also remember, because you also have to go then back to the final rule. That's where, I can't even tell you how much I love Christine and Stephanie and all of you guys on this panel, but we all kind of help each other look for guidance. It's crazy. And Christine's like, well, it's buried page 140 out of 3,033 pages. And then I found the stuff in the CR that was, of course it was, out of 118 pages from 1,500, it was on page 104. It was, of course, at the end. And so, it's never where you hope to find it. But state also, in California, I know in Arizona, we have 2 different rules, for the closest to me. No audio only here. If the patient requests to be in person, you have to have an in-person option. And one of the things that I noticed that they said was extended through the final rule was doctors can still be in their home and use their home address, which I hate, by the way. We're in 2025, pandemic's 2 years old. What are you doing? And so a lot of doctors and a lot of practices framed their telehealth policy or telehealth, workflows from the pandemic. And I'm like, what are you doing? It's temporary. It was temporary. And they just didn't buy it. They said, no, you can't, unring a bell. You can't put the genie back in the bottle, all of that. And I'm just like, guess what? Look what happened. Now, now you're having to go back on that. And they can't see that patient or force them into just telehealth. And I have one doctor who actually had some jail time he was looking at for that. They suspended him and fined him, up the wazoo instead of the jail time. But you have to be very careful because those rules are still in place. And so you have to look at your state. And the last thing, and I know I keep saying the last thing, but has anybody checked their malpractice? A lot of malpractice plans do not have audio only. Let's just put that out there. Yeah, lawsuits are starting to stem up. Well, you saw me, only over the telephone. You really didn't see me. It wasn't even me using my insurance. You took their word for it and all this stuff. And I'm just like, well, did you look at your malpractice before you even entered into any telehealth in 2020? They're like, why did I have to? Medicare said that everyone could do it. I'm like, oh my gosh.
Well, look at Amazon too. They have a wrongful death lawsuit right now.
Huge one. So, and and I'm assuming these panel physicians, there's going to be something coming out at some point because they don't have the patient history.
My favorite is and will remain. Sorry, I was going to say my favorite is and will remain the questions that I get about the providers who want to do telehealth from home while the patient is in the office.
Yeah. Oh my gosh. I get that too. I explain that to me like I'm a 5-year-old. Why would, never mind. Let's move
Yeah.
on.
Let-
No,
I can't,
All right.
Sean.
and
All
the
right.
truth is, Terry, Stephanie, Scott, Paul, Sean, we spend the majority of our lives reviewing notes. And I will tell you, and I'm sorry, guys, the quality of the medical record has deteriorated to a point where we use a lot of copy paste, we're using smart phrases. And at the end of the day, I don't think that providers really understand how that's compromising the quality of patient care. Get back to that. I hear that from doctors all the time. Quality of patient care. Other doctors know what I mean. There's no way the other doctor knows what you mean when all you're using is smart forms, macros. You're not investing into the documentation. I think that to continue to try to push the envelope of telehealth when it doesn't fit is just another injustice to healthcare. Sorry, I'm in
Nope.
my feels today,
But
obviously.
let's use that, because you're right. Because now you've started with the deterioration in the quality of medical records, and I think that allows us to transition perfectly into my topic of the day, which is the Office of Inspector General focusing all of 2025 on the audits tied to services rendered incident to a physician services. Folks, we are off and running. Today is the 6th day of 2025, and I am telling you, there is going to be an awakening for many people, and it's going to
Might
be
be
a
able
very,
to-
what's that?
I was going to say we might be able to eliminate the federal debt.
Quite possibly make a significant dent in it. Folks, this is going to be a very rude awakening for a lot of providers who have failed to listen to their in-house coding experts, their external auditors, their compliance professionals. They're going to have a field day with this, and that's all I'm going to say.
Jack, 1 second.
Yeah.
Just to preface what you're saying. So I'm in the middle of a lot of audits right now where the VA has responded to the OIG audit. I don't know if people really understand. The OIG comes in and it audits and it calls out Medicare, Medicaids. It calls out the VA. It calls out TRICARE and it says, hey, you guys have spent a lot of money processing claims that were not right, that didn't meet the requirements, that weren't even close. So what are you going to do about these millions of dollars that you've paid for? And subsequently, the VA, Medicare, they start doing their audits to recoup this money. So when you talk about the OIG work plan, realize, people, that OIG is calling out the payers and
Yes.
saying, you have wasted our money. What are you doing about it?
Well, there's a reason why the OIG is referred to as the watchdog. And now you have two other watchdogs in DOGE with Vivek Ramaswamy and Elon Musk. Think what you want about these guys, but their focus is to seek out fraud, waste, and abuse within the federal government. Terry and I had an opportunity to chat about this a little bit earlier today. You're talking about a $3 trillion industry, which is what our industry is. I think people need to be very understanding that 2025 is going to be a continuation of 2024, which I called the year of the audit. This is going to be a year of audits unlike any that I think many of us have experienced. I think the fact that the Office of the Inspector General has placed significant focus on enforcement and compliance, and its 2025 initiative is going to have really monumental impact on providers' compliance strategies. And that's what it's going to come down to. This is not a lecture about how to build incident to services. This is a discussion from a well-respected panel of experts on these areas, advising you to take your head out of your backside and start paying attention to what's going on right in front of you. Because when you have providers that are rendering services without direct supervision of a physician, and there's no other physician in the office to provide that supervision for the non-physician practitioner or other ancillary support member, there's no incident to billing services that should take place. If a patient was not first evaluated by a physician who created a plan of care, and then the ongoing services were carried out under that existing plan of care by a non-physician practitioner, it is not an incident to service. Having an office on the first floor and doing services on the third floor with unsupervised auxiliary personnel is not incident to billing services. Having a patient present to the office with an exacerbation or a new complaint whereby a modification to the existing plan of care or a new plan of care is created is not an incident to billing provisional service. That is a service that should be required to be billed under the non-physician practitioner. Folks, I spend more time than any other person I know in federal court dealing with incident to cases. Every single case that I have done for the last 10 years, including those that transpired during the public health emergency that were done via Zoom or other telephonic method or electronic methodologies, every single one of these cases had an element of supervision attached to it, had an element of incident to. Don't take my word for it. Scott Kraft, Paul Spencer, Stephanie Howard, Christine Hall, Terry Fletcher, I've reached out to every single one of them to take a look at something that I'm doing for a case to say, am I losing my mind, or is this a major screw up? Folks, look, the bottom line comes down to this. You can cease your activities of billing incident to, which is the guidance I give to every single one of my clients. The juice isn't worth the squeeze. Get all of your non-physician practitioners credentialed with every single insurance company that you participate with. Take the hit, because the upfront financial hit, which is, so remember, incident to services are reimbursed at 85% of 80%, which is about the equivalent these days of putting cheese on a quarter pounder at McDonald's. Versus having received this money, the Office of the Inspector General conducting an audit. Now remember, OIG does a desk audit. Now here's the difference between an OIG desk audit and an audit conducted by the Centers for Medicare or Medicaid Services or a commercial insurance company. When OIG sends you a demand and says you had an 85% error rate or a 90% error rate or a 100% error rate, which is quite possible with incident to services, you are not reimbursing the government actual damages. OIG has the right under what's referred to as civil monetary penalties to start at double damages. And they have the right to go to treble damages, which is 3 times the amount unlawfully claimed by the organization. So it's not just an actual damage that you're dealing with. I think it was Paul, you and I had a case with our very good friend, Robert Lyles, on behalf of a provider doing pain injections a couple of years ago. And our argument to the prosecutor at the time, and I'm not going to say his name because he's somebody I like. He was the prosecutor for the civil division of the Office of the Inspector General, who said, listen, I understand you're saying that the services were medically necessary, but if they weren't, we wouldn't be here. All the services are medically necessary, right, guys? Yes. So keep this in mind. By asking for double damages, I have the right to actually ask for 3 times the amount unlawfully claimed. I'm letting you guys off easy. Folks, this was a
Sean,
$280,000 settlement. Go ahead.
I think the sentence isn't, is this medically necessary?
Yeah.
The sentence is it medically necessary for this payer to pay that bill? I
Yeah.
agree. I never think my doctor is out there trying to, charge me for something that is not going to be in my best interest.
Right.
But I purchased a policy. I know that my policy is limited to certain things. There's no way that we can monkey this around to try to force my insurance to pay for something that they've already said we don't cover those types of things because
Yeah.
we don't feel like we're responsible. That's what providers are missing. It's half a sentence.
Yeah.
Is it medically necessary for this payer to pay that bill? Maybe I got to pay that bill.
There's 4 quick things that I just want to run down, and I'm going to turn it over to y'all for the last closing thoughts on this. There's 4 things to keep in mind when you're talking about Incident to services. And if you don't meet these 4 things, you haven't met Incident to services. First, are the services being rendered under direct supervision, right? Meaning that the physician has to be physically present in the office suite, but not in the room where the services are being rendered. Second, you have to have an established relationship, meaning an existing plan of care that's being carried out by the non-physician practitioner. Third, you got to make certain that your NP or PA rendering these services is doing so in concert and working within their scope of practice within your state. So you've got to look at the State Nurse Practice Act to make sure that they are not exceeding what they're allowed to do by licensure. And
I
number
want to jump in, Sean.
Yeah.
Or before you go to number 4.
Yeah.
And remember, Incident to is often used not just for the NP or PA, but when you have a medical assistant or a nurse in the office who's performing like an injection. Those CPT codes have a designation whether or not they can be billed Incident to. That's why your medical assistant cannot do arthrocentesis because the code doesn't allow for your medical assistant to get paid under Incident to guidance, regardless. So there's many safeguards in there. You should never say, I didn't know, because it's public. It's part of coding. It's part of billing.
That's right. And the 4th and final thing that I will put out there, and this is the one that Scott Kraft, I always get from him and Terry, is the face plant. Folks, Incident to services take place in an office or clinic setting. These are not services rendered in a hospital. Incident to does not exist in the hospital. Those are referred to as split shared services. So the guidance that I'm going to give you is conduct internal audits. And if you don't have the resources internally to do it, get external resources to assist you in performing audits of the services for Incident to billing, because I am telling you, and this is the last thing that I'm going to say, because Terry and I have a great conversation about this tomorrow. For any of you all out there who are sitting there thinking to yourself, how are they ever going to know who did the service? Folks, there's something called metadata that exists inside every single electronic medical record that tells you the who, the when, the what, and the why information was put into the medical record. These contractors, these SIUs, these UPICs, these RACs, these SMRCs, they are getting smarter. They have more resources at their disposal. They're expanding their workforces. They are engaging with consultants out there to help them identify areas of vulnerability within organizations. But at the end of the day, the biggest watchdog is now barking, and their bite is worse than their bark. And I'm talking about the Office of the Inspector General. All right, let me go around the horn to Stephanie, Christine, Terry, Scott, and Paul. Give us your final thoughts.
So real quick, remember that at a high level, issues with incident 2 can just be seen in your billing data alone. I can run a billing report and look at volume for one provider. I can see one NPI number being billed the same day at multiple locations. We can see high volume not making sense for a medically possible day. This is not something where you should be looking at just documentation. A lot of people think, oh, my macro's good. They say that they talked with the physician. This is fine. No. What does your billing data show?
Right. For me, just remember, a PA assistant is not a PA. A nurse is not a nurse practitioner. A medical assistant is not a nurse. Just because they may have played one on TV in your practice for a long time does not mean that that's who they are. All of us collectively probably have 150 years of clinical and medical experience based on what we do. That does not make us physicians. So you have to be very, very careful and cognitive of not saying, well, they've been with me forever, so through osmosis, they have the same skills and right to bill for services as a physician or a qualified healthcare professional. Don't do it. We're seeing it way too much.
Well said. Scott?
Two things. First off, I do endorse Sean's position of never doing these services, but the two things I would say if you are doing them is remember that CMS clarified an incident 2 service is performed by one provider. So one of the questions I'm asked often is, well, can the doctor just come in and write a plan of care for this one problem and go back on his or her merry way? And they can't do that. That's more of a split shared services, not for the office setting. The second point I want to make, and I've said this on this podcast before, it is the nurse practitioner or the PA. If you insist on doing these services, the mid-level provider has to have a very clear understanding of the incident 2 rules, because when you get into practice workflows, the train leaves the station, and when everybody thinks it's going to be an incident 2 service, the NP or the PA will know if they have made a change to the plan of care, if they've done anything in the room that would make it not an incident 2 service. So they're the ones that have to be able to pump the brakes on your plan to bill something incident 2. If the patient said, well, while I'm here, I have this other problem, and it gets worked up and dealt with, or something gets changed. So I think those are important things to remember, because I don't know how many times, the patient goes and checks out and it gets billed as incident 2 because that's what everybody planned all along, but the NP made a change.
Great points. Paul Spencer, you get the last, we haven't heard from Christine yet, have we, on the last word? So Paul, I'm going to give you the last word, and then Christine, you wrap it up.
Okay. Very quickly, I want to agree with Sean's point about knowing your state laws. I mean, there are 3 basically different levels of, scope of practice that you're dealing with, depending on what state that you're in. You better know those laws, and better, if your state calls for a collaborative agreement between your physicians and your PA or NP, or PAs and NPs, whatever the case may be, you better have those in place, because that is an enormous red flag if you're trying to bill incident 2 services. And that would be all I would have to add.
Excellent. Christine, last word.
All right. I'm going to be very frank with all of our friends out there. There's a lot of moving parts this year. There's a lot of things going on, and we talked about quite a few things. And specifically when we're looking at incident 2, to wrap this up, you really need us. Terry and Stephanie and I are working on a project together, and it came out of my mouth. If this practice were to assign sick visits to this demographic of provider, and follow-up visit to this demographic of provider, and new visits to this demographic of provider, this practice could essentially double or triple their revenue correctly. But without having somebody to come in and help you make those decisions, or to point out those observations to you of how you can be smarter and not harder. I hear providers all the time, I need to start doing more services, new services, to increase revenue. It's not about that. How about you fix what you've got going on immediately, so that you can start collecting that extra revenue? I don't know about you, Sean, but when I go in and do an evaluation of a practice, that evaluation, what we find, pays for our services.
Yeah.
It's almost like getting a bonus for free.
Yep.
Because you brought somebody in that knows how to navigate this and help you put your policy, help you train your staff, help you get moving in the right direction. Lastly, the definition of insanity is doing the same thing over and over and over again. Let's stop the insanity this year.
I agree with you. I think Albert Einstein would also agree with you. All right. So I want to thank our great panel, Christine, Terry, Scott, Paul, Stephanie, who had to jump for a provider education meeting. I want to thank y'all so much for being a part of this first panel of 2025. It was a great one, and I would expect nothing less from this incredible group of healthcare professionals. I want to say thank you and welcome back to all of our friends, our followers, our viewers, our listeners. Thank you so much for being what makes this podcast one of the best podcasts out there. It's because of you that we keep doing this each and every single week. Our panel will be back in 2 weeks. Remember, we are the first and third Monday of each month. Terry and I are every single Tuesday. Terry and I will be back tomorrow with our first brand new hashtag Terry Tuesday episode of 2025. She's already warned me that it's going to be a zinger that I better be aware of and ready for, because I have no idea what it is at this time. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care. All right.